Just as a reminder, tonight is an absolutely must. They put tons of effort to give you the best airway workshop and many, many other surprises upstairs. So after 7 o'clock, just fight your way upstairs. If you're hungry, personally, I would just suggest go to Coop or any of the bakeries, get something quick, and just go back to the bar. You will not regret it. All right?
Yes. 1,700 hours, ready for takeoff. It's wonderful to be back in Zermatt with this, the only perfect mountain in the world, the Toblerone. We'll talk about airways. First, I'll present the core group, Michael Friis Tvede, consultant at the Rigshospital Copenhagen, Denmark, expert in all aspects of airway management, and also medical head over our capital region helicopter Prehospital Medical Service. Søren Rudolph, also close collaborator at Rigshospitalet, almost the same profile, also a lot of pre-hospital work and a lot of scientific work. It all springs out of our daily work and our daily needs. Myself, my name is Michael, same place. I want to tell you how I've got so interested in airways. Very early in my career as an anesthetist, I realized how totally ugly it is, or must be, to lose a patient whom you just talked to and then gave some anesthesia, and then you can't get oxygen in there or CO2 out there. That's even worse than having a trauma that you can't salvage, or an accident or any disease. This is some of the worst. So I want to avoid that. I want to avoid that for all of us in here and for all our colleagues in the future. So we work on that on a daily basis. And luckily our equipment works better than what we got here. It says on. We have another one with fresh juice. Okay. No. Do we have a spare? Of course. I like that answer. Yes. Okay. Good. This is our workplace. Nighttime. The doctors working day and night, as you know, but they can find no cure. Oh, please go back. And there you also see one of our strengths, I guess. We get patients from all over. You see our helipad. We have the same doctors that will meet you on the streets of Copenhagen if you fall in, as we have in hospital for the elective cases. So we can spare and get the best out of both worlds and learn and study from both worlds. And we'll try to use that to improve our practice, and we'll see whether we can make it come through. This is one of the results of that. That's our yearly course, Airway Management for Anesthesiologists. You have that every year in November, December in Copenhagen. This is the toughest 30 hours you can get as a course, because it goes on for a whole day, almost all the evening, night, and then the following day. And then we distill the highlights from this course and bring it to you a month later in Zermatt in even more grandiose surroundings than we have in Copenhagen. And most of the references and videos will be available at our webpage, airwaymanagement.dk. It's departmental based, not for profit. Yesterday, I spoke with Ross Fisher in the bar for an hour almost. We shared a Macallan 12-year-old whiskey, and I learned that slide presentations is no use. But if we read a paper on instruction, then we'll remember. So luckily, we did that. We put all our efforts into a new airway management book, invited 60 other experts from around the world to contribute. So there you can get maybe 80% of what we're going to say. But development is so fast that there will be news for everyone, I think. Then before you Swedes and Norwegians and Americans start teasing us, I better attack Danes and ski. We know that we are known for for not being good at that. We have no mountains. We're such a flat concept. But in Copenhagen, we constructed one. This is on top of the world's most modern combustion plant. So all energy or electricity or high percentage for Copenhagen heat is made in there. And on top, we place the ski slope. This is the view from up there. And you see, and this is the after ski bar, and the view from there is actually excellent. Yes, so we try, and we got a joker up the sleeve. This is main Denmark, but we got, as part of our kingdom, we got the world's largest island, Greenland, and there we got snow and ice to beat Switzerland and Norway. Ha! And this is the mean of transportation north. First you fly to Thule Air Base, then you fly an hour in helicopter to Qaanaaq, then you go 1 day by dog sleigh to Siurapaluk. This is my driver, Usakak, and the cigar is just brought home from Havana, Cuba. This is, they all shot the polar bear themselves, by the way, our drivers there. And then being there up there, north, looking at this mountain 3 kilometers out in the frozen fjord, I thought, is it possible to ski an iceberg? Now we don't have real mountains. And I put on the skins, and it is possible to get up at least, but I tell you it's difficult to get down because it's a pure ice cube underneath, so you have to have very good steel edges on your telemark skis to get down in style. With us today as lecturers, we are so fortunate we got 3 colleagues. Sandra Elfsen from Stavanger, Norway, assistant clinical professor, and volunteer job in Africa and India, and being, as you see, the uniform in the services in Afghanistan, dealing with all kind of disasters, including airways. Richard Levitan, our emergency physician that you all know, of course, for many years gave us so many aspects of airway management. I remember one of your early inventions, the scope that you actually could see through with optical fibers. Excellent tool, and many, many others. You will also contribute to this. Thank you very much. Jim DuCanto, that we especially learned to know for teaching us how to get rid of all this vomit and blood very efficiently, and it's really a cornerstone technique. And we got all, maybe 5% of you to contribute to the workshop tonight. We've got Prims from the Netherlands, Anne-Sophie from Denmark. We've got Jörg here from Switzerland. We've got John from Geneva. We've got Christian from Denmark, Tatjana also from Switzerland, and Katrine from Denmark, and Helene from the Netherlands. And we'll take questions and discussions after the talks. Okay, so this is what we are going to go through. Save the Savior. Airway management, what is it? Why should that be important? Plan, prediction, preparation, accommodation, and special circumstances. Breaking news, and the future. And then hands-on. Most of what we talk about, you'll actually be able to practice and discuss. We are so fortunate that this is a two-way discussion. You are all very experienced in each your field, so we want this to be an exchange of knowledge, not a one-way transmission. So we aim for that, and we think we'll survive or obtain that. Save the Savior. This girl is Majbert. She's from Lofoten in Norway, and we met her on the plane on our way to Geneva 2 days ago. And she tells us, first we need to save ourselves in order to be able to save children or other persons. That could be our patients. So the doctor has to stay healthy, otherwise our patients will suffer. And this has been very actual in the corona times, and it seems that we'll get new pandemics with short notice from now on. And this is where you get the most bang for the buck in protecting against airborne disease. On extubation, actually...
Normally, the person extubating gets sputum in his eyes, nose, or mouth from the patient in 0.2 to 6% of cases. To avoid that, suction beforehand if needed. Place a surgical mask on the patient before extubation and leave it there.
Place the nasal oxygen cannula before extubation. Leave the filter on the tube. Place the surgical mask on the patient.
very
Extubate.
efficient at awakening the patients in Denmark.
Leave the mask on the patient, also in the recovery room.
So simple and so cheap. So if we do that, we will we'll stay alive to the next steps. What is airway management? It keeps being bloody fascinating. It deals with this tiny piece of anatomy from out here, fresh air, down to somewhere in the trachea, maybe the bronchi. And why should that be important? From the moment we cut the umbilical cord, and then the next 92 years, or what we can hope for, we are dependent on the open airway. Otherwise, a few minutes we'll get brain damage, a few more minutes we'll die. Some exceptions, of course. If you're on ECMO, we may have a little longer time. If we had our heads submerged in cold water, we can also survive a little bit longer, but we cannot count on that for daily practice. And the interesting thing is, it's our responsibility. Many of us are anesthetists, emergency room physicians, ICU doctors, and prehospital doctors. There are no other specialties that can take over this responsibility of recognizing a threatened airway and managing it. So it's our responsibility. This is an old study, but it's still the best, and we can extract a lot of knowledge. The NAP4 study, 1 year data in all of National Health Systems hospitals. These are either death or brain damage or unplanned cricothyrotomy, unplanned ICU admission. And you see a lot in related to general anesthesia, ICU, and what's interesting is that we can do better in most of the cases, and ICU and emergency is highly overrepresented. And this is only the tip of the iceberg. The real data is worse, and this is what makes it worth talking about today. Most often preventable. If you look at this case and say, can we do better next time? Yes, in maybe 80% of cases, we do better, and we can avoid by far the majority of these cases. So this happens. We, our colleagues at that time, failed to plan, and we probably do as well. And if people planned here, they failed to follow the plan. So how do we choose which of these 7 ways of oxygenation and CO2 removal from our patient? Either we can do nothing, or we can put on some nasal oxygen, and we can put a face mask, or we could put the face mask down via the mouth to cover the larynx, then it's called a supraglottic airway. We could put it further into the trachea, then we call it an endotracheal tube, and the mask is now the cuff. We can put it via the anterior neck, or we can cannulate the large vessels and use ECMO heart-lung machine. So by a little thought and examination, we can plan which one should we choose. And we can also plan if we want the patient to be awake, anesthetized breathing spontaneously, or anesthetized and apneic. So it gives us a lot of possibilities to manage the individual patient if we have a plan. This is an even bigger resort. This is the longest, the peak-to-peak gondola over in Whistler. Okay, plan prediction. There are many guidelines out there, and tomorrow Rich will tell us that guidelines cannot solve every problem, and yes, I totally agree. Sometimes we just have to react to the actual circumstances, but sometimes it can, and we saw that from the NAP4 study. Many of you have read the American guidelines. I have a postulate that these are mainly made to keep American doctors out of jail and to keep their hospitals from paying large refunds for damages. They're so defensive and not useful for clinical work. That's my opinion. You can contradict me. I'm willing to discuss it. These are the Canadian guidelines. They're more written by clinicians, for clinicians. They're actually like a whole textbook in airway management. So we'll see what they suggest to have a framework for the next discussion and for the hands-on work. So they say that prior to airway management, we should have a strategy documented and formulated for every patient based on airway evaluation. Does that have to be a long and cumbersome thing? No, it's easy and fast even.
Okay, prøv at åbne munden alt hvad du kan, og ræk tungen ud alt hvad du kan. Og så prøv at tage tungen ind og lave underbid, som du bider dig selv i overlæben, ja. Og så prøv Og kig op i luften bagover så meget du kan. Den er fin, så mærker jeg lige her. Okay. Og her. Okay.
It only takes 15 seconds. And the good thing is, the patient cannot avoid smiling when you ask them to do this, so you have a good contact with the patient. And when you do this with a lot of patients, in this study, Danish study, 64,000, it was possible to predict more than half of the difficult intubations, and they are likely to be the most obvious and the most difficult patients that you identify. So by this simple, a bit of airway history and this simple examination, we can actually stratify our patients in some likely to be easy and some likely to be difficult, and we'll probably, with little effort, be able to identify the worst cases. And this is even useful for video laryngoscopy. It's difficult to predict, but these guys use the same scoring system. And then, of course, it has to be worse for the video laryngoscope not to work, but still it gives us a hint, will this work in this patient? So I can, without doubt, say yes, it is valuable. What can we use this evaluation, airway evaluation for? We can use it for making our plan. And I'll only go through the highlights here, just don't worry. These are the Canadian guidelines. They start by this, if we encounter this situation, difficult tracheal intubation is predicted based on maybe this, this examination. If that's the case, what can we do then? Then they suggest we pose ourselves a few additional questions in order to make a decision. Is there obvious need for an awake tracheal intubation? And that could be patient cannot open the mouth at all, or the neck is fixed like this. If that's the case, yes, then we go to the right. If that's not the case, are we likely to be able to ventilate with a mask or with a supraglottic airway? If there are likely to be difficulty is the question. If say no, then we go on to ask ourselves, are there adverse physiological issues? And I'm sure that you will touch on that tomorrow, Rich, so I'll not go into depth of this. That could be hypoxia or bad circulation are the main killers there. Then they forgot something here, but they have it in the text. Is it likely to be difficult and impossible to make a surgical airway, a front of neck airway access? That we have to ask ourselves that as well. And then, are there complicating contextual issues? The context here, are we in a bad place or with a bad crew? Then maybe we'll have difficulty to do something else. We'll come back to that later in the lecture. If you can say no to that as well, then it should be safe to go on with induction of anesthesia with the proper technique planned. That could be a video laryngoscope, for instance. If we say yes to any of these questions, then we should at least think about maybe we should do awake intubation, and we should ask ourselves, can the patient cooperate with this, and is there time for this? If that's the case, then we should definitely consider to secure the airway awake, either tracheostomy or intubation. Why on earth awake? Why is that valuable? There are many advantages. The patent airway is preserved because of tonus in the muscles. Spontaneous breathing is preserved. We don't have to force air into the patient. We can easily find epiglottis if we go there because we've got the bubbles coming up and down from trachea. The patient can help us. For instance, we can ask, please, would you protrude your tongue? And he'll do so. Will you protrude your jaw? Oh, yes, I will. And then we get easier access. And then the patient can be sitting up and protection against aspiration and neurological status, and we can do decision making, and we avoid the cardiovascular depression. If we put the patient to sleep but keep him breathing, then we got some of these advantages, but not all. And if we put the patient to sleep and make him apneic again, then we can say no to all of these. So this is a tool we have. We can plan what do we want here, which technique and which state of awakeness or breathing. So that was the argument for awake intubation. If we can say no here, despite there were some alarming factors, there is no time or the patient cannot collaborate, then we can consider airway double setup. And that is this, that we mark the location of cricoid membrane, if necessary with ultrasound. You'll learn that, all of you. We decide who should do the cricothyrotomy if we need it. We make sure that we have the equipment ready, and we brief the team who should do this if this and this happens, so that we know in advance. That's called the airway double setup. If we have that, it will often be defendable to put the patient to sleep and then see if we can intubate. If we can't, we are ready for the front of the neck airway access. There is another possibility, keep the patient breathing spontaneously. We can hit on that next year. Okay, if on the other hand, we are into trouble, the patient is already apneic, then the situation is different. And if we can't intubate there, then of course there may be other means. If we can't, then we should prepare for front of neck airway access while we try to improve the situation. And if it's not possible, we need to make a hole in the anterior airway. And we'll get to learn a lot about that. Yeah, so I press this. Yeah, how can we further improve success? We can combine some of these techniques. It's not either this or this. Very often a combination will save the day. And we have all these wonderful tools, and we have many more than we have here, and they can be combined to change failure to success. The first one, a very known one is, of course, flexible optic intubation via supraglottic airway. You can all try that at the workshop by one of our experts who can make this into a smooth procedure for you. I like this one. It's the cheapest and simplest we can imagine. We just take the tube and an ambu bag, and we have our next speaker here. Sandra, please tell us how we can use this simple equipment.
Thank you, Michael. Oh, you'll get more. Okay. Do I have like a clicker? Okay. My name is Sandra Ellefsen. I work as a resident in anesthesiology and as an assistant professor in Stavanger, which is in Norway. First of all, I'm super thankful to be here to meet you all and learn from you and be inspired by you all, so thank you all very much for that. These are my collaboration partners for this presentation. It's Michael Selz Kristensen, the airway guru that you've all seen now for a little bit, and Anja Stubager, which is the nurse anesthetist that experienced the case that I will be presenting shortly. So airway management and establishing airway patency is the cornerstone of anesthetic practice. And throughout the past couple of decades, we've had several advances made in the safe management of the airway. These are, however, not always at one's disposal, and especially not in austere, low-resource settings. So if you're in a situation where you're not fortunate enough to have the whole array of various gadgets at hand, there is one technique that can be used, a technique which is intended to obtain airway patency in those cases where especially where the cases where regular BVM ventilation fails. So the aim of this presentation is to highlight the TTIP technique, the tube tip in Pharynx technique, which is a simple method that might save a potentially life-threatening situation in a matter of seconds. It's a simple single-handed technique, and it requires minimal and readily available equipment. And I would like to illustrate the efficacy of this technique through a case presentation from Nigeria in Africa, in Port Harcourt. This is an email that Michael received shortly after this happened. I know all of you are extremely talented people, but I do suspect that some of you are at least not fluent in the Scandinavian languages. So I'm going to take the liberty to try and extract the essence, which also beautifully describes the situation. Dear Michael, you have indirectly contributed to saving the life of one of my patients tonight here in Africa. It's because you taught me the TTIP technique. We were in a terrible cannot intubate, cannot ventilate situation with a man who needed an urgent laparotomy. He was shot down in front of his house while his wife and children were watching. Our challenge is that we can only give 5 liters of oxygen per minute, and we have no nasal airway. This man was 100 kilos, which equates to around 220 pounds for you Americans, with a short neck and a big belly. I'm not going to bore you with translating the entire email. Instead, I've tried to summarize the main events in this table right here, and the rest of what happened is here. But essentially what ended up happening was that they had 3 failed intubation attempts with consequent desaturation in the patient, where the TTIP technique was utilized several times where they were able to bring the patient's sats back up. And in the end, they were able to perform an awake airway, or like a surgical airway, under local anesthesia, and then they could continue with the surgery. Now, a whole lot can be said and debated around the case itself and the management, but that is really not the point. The point here is to illustrate that the TTIP technique in this case was utilized several times successfully in a situation where nothing else worked, which consecutively contributed in saving this man's life. And the TTIP technique is showed here, where you basically place the endotracheal tube down in the patient's pharynx with the tube tip in the pharynx. And then you inflate the cuff, and that's in order to push the base of the tongue away from the soft palate and the surrounding tissue. And then once you do that, you enclose the patient's mouth and nostrils, creating a seal like they do here. And as you can see, you also have a little chin lift inherent in the grip, contributing in opening up the airway. And this is the classic technique where you, like they're showing here. You also have something that we like to call a fast technique, where you do this, you sort of just mush your hand around the patient's face. You reach the same goal. You're able to, like, I don't give a rat's ass how you hold it as long as we can oxygenate the patient, right? So it's the same thing. Here you have the classic technique and the fast technique, but the premise and the end result is the same. A lot of people know about this technique from managing pediatric airways, but they tend to forget, or they don't know that you can actually use it in adults as well. And it even works in patients that are obese. So possible indications to use this technique would be a difficult or impossible bag mask ventilation, or if you have a difficulty with the LMA placement, or maybe you don't even have it. Or you can even use it as a conduit for fiber optic intubation, which you will see in one of the stations in the workshop later. However, it's not widely taught or practiced, not anywhere I know at least. And studies should definitely be performed to obtain precise indications and limitations. But the take-home messages from this is that airway management can be extremely, like, simple is good, and it doesn't have to be expensive to be effective. And I would like you to remember the TTIP technique as a potential maneuver, and just have that in your arsenal of tools when managing an airway. And that's all I wanted to say. Thank you very much. I'm going to say more, apparently. Okay. It doesn't work. All right. So now we're going to go into the fiber optic side of things, where you can actually use this technique as a conduit for the fiber optic scope. So what if you have a patient where you have extremely limited mouth opening, like this patient right here? Placing an LMA would be difficult. You won't fit it. You won't be able to put it through the mouth. For like anatomical reasons, or the pathology, you weren't able to do it via the nose. And so what can you do? Yeah, you can use the tube itself, the endotracheal tube, in the same way, and use that as a guidance. Yes, so here you have, you can say, like, okay, maybe we can do the surgical airway, but that seems a little excessive. It might not be necessary. So you can actually try and do this. can also do like place some local anesthetic,
Lige åbn munden så meget du kan. Jeg ved godt det.
and the patient is awake, she's spontaneously breathing,
Og
Det kan måske føles lidt svært.
stik tungen lidt frem. Den er god. Sådan, og så må du godt bide lidt
and the
sammen.
patient is cooperating the entire way, and it's just about making, as long as they're comfortable with what you're doing.
Skal du tage kamera på maskinen også?
Det skal lige præcis. Du er fuldstændig ret. Godt, Karl Martin. Det skal vi nemlig. Det var lige det, der vi aftalte. Godt. Tak for det.
So here you might find that you have to take the endotracheal tube back a little bit or further, but the point is that it provides a really good guidance to bring the scope in, and it doesn't. Any secretion does not occlude like the tip of the camera.
Det spænder lidt ind i munden. Prøv at se, om du kan lade være med at bide i den så. Tak for det. Sådan, prøv at se, du går hen og se, om du kan komme ud. Så prøv at trække lidt tilbage. Så tror jeg, du kan komme forbi.
So now they're doing that. They're just trying to find the right place. Now we might start to see something that looks a little bit familiar.
Ja. Det er åbnet tommelfinger, så tager ned, og så trækker vejret dybt en gang.
Oh, there we go.
Fint, og du fortsætter bare, fordi vi har så god lokal, så regner ikke med, at det er nødvendigt.
And the local anesthetic that they put in
Så holder vi op med at
transcutaneously is working really well, and you can add on
Tak skal du have.
through
Det er fordi, jeg kigger
through the tube here as they're doing.
Yes. Og prøv at se, hvor smukt det er med venstreren der, var. Helt 100% perfekt. Intet mindre end perfekt, det her.
And there you see the cannula that they placed with the transcutaneous local anesthetic. You go down the trachea, you identify the carina. Okay, we know we're in the right place.
Susanne, du ved lige så snart, at tuben er på plads, så
Ja,
får du
det er
lidt
så godt lokalt, så det er det. Så vær venlig at åbne munden det du kan. Det er lige en millimeter med her, så avancerer du tuben. Og jeg har tømt koppen, og så kun bliver ikke at stoppe skobet for langt ned. Og det kan også få mig til at avancere. Så mens du trækker skobet lidt tilbage, så avancerer jeg, og du holder. Og du trækker vejret dybt, og trækker vejret dybt igen, og igen. Og en gang til.
så godt.
Ja, og så går lidt op med skobet. Og så holder du skobet der, og så har vi tuben.
And as in any other flexible scope intubations, you retract the scope to see that the tube is in the right place. We can see that, okay, it's a nice distance from the carina, and you do it the way you always do it with a regular awake intubation. And now she can go to sleep.
Sådan, så kommer til at sove rigtig godt, og så får vi vores dygtige kirurger til at lave det der op.
Whoops. Okay. So that's what all I was going to say. Yeah.
Thank you very much. So, cheap things that we have everywhere that can be a huge use both in the bush and in the operating room. Aye. Okay. Now, this is a complicated situation, especially if it's in a patient with a anatomically difficult airway. The patient is sitting up. This is the patient. This is the surgeon compressing the airway. As soon as she lets go, it starts pouring because he's compressing where it was a cancer bleeding. And this is the anesthetist who thinks, I wonder I had read some kind of paper or ever had a course telling me how to manage this bloody airway. But we realized that there wasn't such a thing, so we had to do it ourselves to find out what's useful in this situation. Can we come up with a plan that can be used both in the anatomically easy and the anatomically difficult airway? And I take the chapter from the book, and all these wonderful techniques, but if we have a lot of blood or secretion, these techniques may become totally useless. So we are left with some basic techniques and skill and planning capabilities. So let's have a plan. This is this account for them all. Compress the bleeding, sit the patient up, suction and give oxygen. We get to that. Make sure to fluid resuscitate so that we don't kill the patient if we give general anesthesia. And then evaluate the airway and identify the cricoid membrane. And we evaluate the airway with special emphasis on are we likely to be able to do a direct laryngoscopy, because we cannot count on the flexible scopes or the videolaryngoscopes because they may be rendered useless due to the blood. And if we can predict successful direct laryngoscopy and the cricoid membrane is identified, then we can go on with a rapid sequence induction and intubation. That will be the typical case post-tonsillectomy, for instance. Young people, easy airway, but pouring blood, but it's defendable to follow this procedure and make a rapid sequence induction. But we have to get rid of the blood during the procedure. Jim, please help us do that in an efficient way. I'd appreciate that. Jim DuCanto.
Thank you very much. Oh, I need the clicker. Yeah. I'll start my little timer. All right. Hey, thanks for inviting me, and thanks for the course organizers to invite me. My financial disclosures are that I've invented a mannequin and the DuCanto suction catheter. I came up with a project in simulation that actually works clinically. It's called suction-assisted laryngoscopy with airway decontamination. This is a procedure where we're using the suction catheter to actually create intraoral and hypopharyngeal space, simultaneously decontaminating the airway while creating space to place the laryngoscope. This is a paper from 2020 that is a review of the techniques as well as the 6 simulation studies that exist. Pathophysiology of airway contamination is such that it basically neutralizes your ability to deliver oxygen, either passively with normal nasal cannula, high flow nasal cannula, supraglottic airway, and it defeats all video systems. It defeats your bronchoscopy, your video laryngoscopy, unless you have a specific approach to the airway. So this is a little GIF I created on placing a supraglottic airway in a contaminated airway. It's a suction-assisted technique to place a supraglottic airway. SALAD technique manages the airway contamination while assisting you in placing your airway modalities, whether it is a supraglottic or a laryngoscope. When I teach this to my emergency medical service colleagues, I focus initially on the supraglottics, and then I transition to laryngoscopy. This is can you roll the video for me instead of me goofing around? Oops, one back. Roll it. It's just a demonstration of the technique. I don't believe there's video. Oh, there's no video, okay. Okay, let's take a look at, can you roll this video? This is a video where the SALAD technique is not utilized. We have CPR ongoing. It's obviously either pulmonary edema or some condition. The endoscopist plunges into the airway with a CMAC. As you can see, it's a failed intubation. The second colleague, who very shortly, 25 seconds later, utilizes the SALAD technique, wipes off the optics, re-enters the airway, leading with suction and using the suction to create intraoral and hypopharyngeal space while protecting the optics. He is hugging the base of tongue as he comes around the base of tongue with the suction ahead. It's like shoveling snow before you walk out and slip on your driveway. He's going to take the suction and put it to the left of the video laryngoscope now. This is to maintain decontamination of the hypopharynx during tracheal tube delivery. Here it comes. He's not messing around. Bammo. The next video is a live video from Mexico City. There's an academic department. You can roll this one for me. It's an active CPR. This is under direct laryngoscopy. This is a first-year resident in emergency medicine in Mexico City. I'm not going to show you the whole video, but she does get this airway, but she's shaking her head. Hell no. She gets this airway because she's relentless in leading with suction. The technique encompasses a few maneuvers. Number one, instead of doing our standard maneuvers to open the mouth with our fingers, we call this a scissor maneuver in the United States. We're actually going to hold the suction upside down with the point pointing down and away from ourselves, and we're going to use it as an airway management tool. My goodness, you already have the equipment you need to do this. You don't need to buy anything special. Yankauer catheters will work if they're stiff enough, and you use the open tip variety. There's a large bore suction available on the market still, called a DuCanto, that does work as well. You're going to go ahead and you're going to smush the tongue into the floor of the mouth and distract the mandible inferiorly. You're going to open the oral pharynx, open it, and then you're going to lift a little bit to open the hypopharynx to pull the epiglottis off the posterior pharyngeal wall to allow you to place your laryngoscope. And as you get in there, you can't leave the suction on the right side of the scope unless you're using a channeled scope. You've got to move it to the left. Otherwise, there's no room for tracheal tube delivery. That's the basics of what's called the salad park maneuver. When we were first really creating this, I used a little bit of imagery from Jurassic Park. It's salad park. Now, for those of you who use hypercurved video laryngoscopes like the glide scope, it's very common to get the dang laryngoscope too far over to the right corner of the mouth. Now you have no room to put the tracheal tube in. What you gotta do is easy. You stick your finger right in the freaking mouth. You move the laryngoscope more towards the midline and create space. The reason we want to do this is if you look at that little picture circling the right palatoglossal arch, one of the most common injuries with a glide scope in a rigid stylet is piercing the right palatoglossal arch, because as the tracheal tube transits the mouth along the right side of the oral pharynx and then the hypopharynx, it grabs that palatoglossal arch and bang, right through, you pierce it. You don't want to do that. The next video, I'll ask you to roll it, is a self-inflicted, sorry, I'll let you do it. Forgive me. You can just advance once? This is a one back, it's a horrible video. It's a gunshot wound to the face. Is no video? Darn it. Oh, I'm sorry the video didn't come through. It's a self-inflicted gunshot wound to the face. This was this paramedic's first field intubation with this service, and using the salad technique, he was successful. All right, so what do we got here? We're predicted unsuccessful direct laryngoscopy or cricothyrotomy. I think this is Michael's. That's my last slide. I got it done in 6 minutes, Michael.
Oh, that's a new. So short and precise. Thank you very much, Jim.
Thank you very much.
Thank you. No, not yet. And it really makes a lot of difference, this efficient suction. I must admit that saved us several times, so thank you very much for this. Then we are in the other situation here, this leg, where either direct laryngoscopy or cricothyroidotomy is likely to be difficult. So now we cannot rely on just suction, because even if we suction everything away, it'll still be difficult. And you see the cricothyroid membrane plays a crucial role here, this tiny piece of anatomy, but when anesthetists try to access that, we had, or used to have, a very low first pass success rate at least. So we've been working on trying to improve that. One of the reasons is that it's not that easy to find the trachea or the cricothyroid membrane. And the worst thing is, if it's not in the midline, then we cannot even rely on any kind of palpation or just longitudinal incision. This is one of my patients, Dagmar, for instance. This is the day before. I have a pre-anesthetic visit, and I look at her. I say, yeah, I don't think I need a frontal neck airway access, but if I do, where should I put my knife? Should it be here in the midline, where some guidelines say just cut along incision in the midline, or should it be here or here or here? Where should the cricothyroid membrane be? It could be anywhere here. I try to palpate. I can't feel anything. So where to put the knife? That's a question. We can use ultrasonography for that, and you'll get a very good and short, brief, step-by-step hands-on guidance if you want to at the workshop. We look forward to that. You'll be able to practice this stepwise, simple technique. It relies on the first, if the patient is alive, then there must be a windpipe coming up from the thorax somewhere. And it looks like this, a black horseshoe with a white lining, that's a tracheal ring. The black is because cartilage transmits air, so it's dark. And the white is where the ultrasound beam reaches air, and there's a high increase in resistance, so it gives a strong echo. This is the midpoint of this patient's airway. Then we slide the transducer towards ourselves until we kind of truncate trachea in half like this, because then we know that if we rotate the free end of the probe up here, we'll get a longitudinal image of this patient's trachea. It may not be in the midline of the patient, but it's the midline of the airway. And then we get this beautiful image, the black pearls on the white string. The black pearls, that's the anterior part of tracheal rings. Black because it's cartilage, transmits ultrasound well. The white line is the tissue air border, so anything beyond that, that's in trachea, and this is artifact. We can't see any structure here, but that's not necessary. We know we are on the midpoint of the air, of the trachea. We can move a bit cranially until we encounter this cousin here. It's one of the rings that is larger, more anterior, more cranial than the other ones. That is, of course, the cricoid cartilage, and then we move a bit further cranially until we encounter the thyroid cartilage. And here we can place a marker with a pen. You can practice that. So we got the longitudinal course of the airway, and then we can slide some kind of needle under the transducer here. You see, this is the echo from the needle until we are here between the cricoid and the thyroid cartilage. This is the midpoint of the cricothyroid membrane. We place 2 marks here. We lift the transducer, place 2 more marks, and if we connect those, we got the midpoint. We studied that in several patient categories. It's very precise, and it's fast, and it's cheap and reliable. This is how it looks in a patient who has a short neck, radiation therapy, can only open the mouth 1.8 centimeter. He's awake. It's before, in this case, before awake intubation. I want to know where is his windpipe, where is his cricothyroid membrane. I follow the technique I showed you beforehand. Now I slide the needle. You see it coming in from the left up here. This is the echo. Put a mark, and we got the midpoint. In this case, I want to be confirmed, so I do a transverse scan for confirmation. That's not strictly necessary, more for the video purpose. I find the same location, and to demonstrate that this is no humbug, we we go through it, through the membrane to see if it really encounters air. And this is then a needle cricothyrotomy in order to, in this case, in order to give local anesthesia before awake intubation. It could also be for retrograde intubation that you can practice up here, or for insufflation of oxygen. And we are ready for next step in airway management. So in this lady, Dagmar, this is then the day after on the operating table. You see with ultrasonography, we identify her trachea and her cricothyroid membrane over here, 5-6 centimeters displaced, and that corresponds very well with a CT scan. But CT scan is less useful in the clinical situation because that will not tell you exactly where to go, whereas this will. So no blind incision in the midline and not relying on palpation in this kind of patients. Okay, in this category over here, now we're in the bleeding airway. We have the predicted difficult direct laryngoscopy. We can either do an awake cricothyrotomy or an awake intubation with another technique. So now we mentioned cricothyrotomy a lot of times, so we need an expert to tell us more about this tiny but often very efficient. And please, Richard.
Thank you, Michael. What a great talk. I'm just going to take a cue from Jim here and start my presentation. A shout out to the folks who invited me back. It's been 5 years with the length of 5 long winters between COVID and everything else, but it is great to be back. That's quite a setup, Mike. You said, don't make a blind incision. Well, I'm going to make the blind incision. But I work in a different world than elective anesthesia. I work in the world of where everybody who's getting intubated is dying. So it's a little different. I did a cric actually a few weeks ago. It was a woman who choked to death, basically, and was brought in. And yeah, my first technique out of the gate was cutting her neck because EMS had tried multiple times. Okay, so let me start this, and I want to get to some videos. If we could bring up the talk here. Wonderful. So I just want to mention a shout out to Laura Dugan. If you're not familiar with this paper, you should see it. She has written the best summary of why you do not want to do needle cric, but I'm not going to go into that. Okay, so we have called this the failed airway. And what that means is you failed, you suck. And what we have come to believe is that when we get to the end of multiple laryngoscopies or endoscopies or whatever, and we're cutting the neck, that it's bad. Well, what that has done is it has taught us to delay doing it because the stigma itself attached with it. We need to get past that mindset. Sometimes to save a life, you need to use a knife. We should be trying to oxygenate as best as we can. But remember that mantra, to save a life, I need to use a knife. And if you are a surgeon, this is embedded in your brain. It is because we are emerge docs and anesthesiologists and others, we've been taught a knife is failure. It's not failure. To save a life, you sometimes need to use a knife. As Jim has said, and he is the master of vomitology. He is the nemesis of emesis. Jim, I love your enthusiasm. It is incredible. Anyway, so, but yeah, high volume fluids are the enemy of everything good in the airway. But, so, let's get on to common misperceptions of crics. First off, I think a lot of us are filled with fear about this procedure because we haven't spent enough time in the neck. Michael doing these punctures of people, that was an aha moment for me. I have done a handful of them. I don't do them routinely, but I've done a handful of them. And after you start puncturing tracheas and realizing, there's the cricothyroid, and this isn't a big deal, that was an important thing. So I think, you know, if you're working in head and neck and you're doing a lot of these, that's part of what lowers your fear threshold. But it's about not knowing the anatomy enough. We're hesitant to start because what we have set up as the first step of this procedure, with one hand, 1 centimeter, with your heart rate at 120 beats a minute, and fine motor goes at 115, you're trying to find the cricothyroid. And in your brain, what you're saying is, oh shit, oh shit, oh shit, and you can't find the damn cricothyroid membrane. So then you don't want to cut because you don't know where the membrane is. So we have to think about how we engineer our practice. We do not want the first step in a procedure to be something we can't do. Okay, so this whole business about skill and comfort, well, I'm not comfortable cutting. Yeah, like we need to move past this. So the mantras of a surgical cric: to save a life, I need to use a knife. The laryngeal handshake will find midline. Not in Michael's patient, but in 99.99% of the world. I will find the cricothyroid membrane after the vertical skin incision. This is a big deal. If you think the first step to cric is find the CTM and you can't do it, you won't start. After we make the incision, and I'll show you this in my models upstairs, you can find it. I'm not a surgeon, but I can stabilize my hand on the sternum, and this is a big deal, a principle of surgical performance. You stabilize your hand. The cartilaginous cage will protect. What do I mean by that? We're going to talk about the anatomy. Self-inflicted, swallowed 2/8 of a stick of dynamite, something called an M80, trying to kill himself. Surgical airway. I call this the surgical inevitable airway. One of the things that we need to do in cases, and I'm not going to show you a ton of airway porn, but there is, when it comes to bad airways, we need permission to cut. This person is gonna get a surgical airway. So this is self-inflicted gunshot. In America, we get 20,000 of these a year, self-inflicted gunshot. We have a lot of practice on this. Anyway, most of the time RSI works. But what you can't go into this is you can't go into it thinking I can rescue oxygenate. You can't do high flow. You can't do O's up the nose. You can't do supraglottics. You're not gonna bag them. So it is RSI with the neck prepped. And if you cut this person right out of the gate, I would not fault you. You know, if you're alone working with 2 nurses in an ER in the middle of nowhere, which is my practice, cutting this guy's neck, he's got plenty of other bigger issues. There's bullet going to his brain, right? This is a 1-inch freaking incision. Just get over it. Anyway, here's a stab wound to the face, lingual hematoma. Back bottom right here is Matt and Mike, the ultrasound podcast. They RSI'd a guy in respiratory distress. Turns out he had epiglottitis. And what was funny was Mike told me, hey, Rich, I didn't use an ultrasound. He's going to show you the technique that I used. All right, so I have these models. They came from Lewis Thomas Jefferson, a zoo. In 1835, I made them. And some of the things we want to emphasize are the overlap of the thyroid on the cricoid. The thyroid spans from the hyoid to the cricoid. This I call the rhomboid, and we can rock the rhomboid when we do our laryngeal handshake. The back wall of the cricoid is 30 millimeters high. The front is small, but take a look here at the rhomboid. So how do we find landmarks if I told you finding the CTM isn't the thing to do? I think we should do the laryngeal handshake, but let's look at the mobility of the larynx side to side and up and down in this young man. It's impressive how much the larynx works, which protects us in blunt trauma, but when we do surgical airway, we have to stabilize it in 2 planes. But instead of using your finger, which I think is a bad engineering technique, we want to be mindful of difference in male and female. And by the way, upstairs in the workshop are the only surgical models made with female anatomy. So just a weird point here, 50% of the population, and there does not exist surgical models made for female anatomy. Huh? All right, weird. All right, so laryngeal handshake. We're going to apply our fingers basically around the larynx. We're going to rock it from side to side. It's going to identify midline. And this is my ex-wife, and she let me do this, and we're still friends. I didn't cut her, just saying, but I did palpate her neck. But we moved from the hyoid down, and here's the cartilaginous cage. So once you do this in a lot of cadavers, and I spent the last 20 years with 20 bodies every month, plus going to Australia and New Zealand and afar, after 500 cadaver courses, thousands of sticking my fingers into people's larynxes, albeit dead people, the back wall of the cricoid cartilage is as hard as this table. And that was an aha moment for me. The thyroid overlaps the cricoid on each side. That meant my knife wasn't going too far laterally if I was in the right location. So anyway, here's a video, if we can play it, let's see here, of going back and forth. Well, this is where we're cutting, and not sure it will play. Ah, there it is. So I look at every CAT scan I have to learn this anatomy, to burn it into my brain. But we've got thyroid here, and there's cricothyroid, and there's cricoid. And you see how high the back wall is. And did you notice right there, look at how low down the inferior cornu of the thyroid goes. So a big part of my being able to do this procedure in real patients is changing my mindset and losing the fear of this, that you are aiming at something as hard as a table if you're in the right location. So the ergonomics of this, non-dominant hand is going to stabilize, the cutting hand is going to be stabilized on the sternum. You want to be on the right side of the patient if you're right-handed, left side if you're left-handed. We're going to practice this upstairs. But we want to put our finger in the hole. The most common error is people cut to air, puncture happens, air sprays, and then you try taking something too big and putting it in a hole. And the same errors happen with chest tubes. So the way to not fail at a subcutaneous placement of a surgical airway is to make sure your fingertip fits in the hole. So some people are keen on the bougie, that's okay, but put your finger first. We're going to use our non-dominant to stabilize. It doesn't move throughout the whole procedure, and our second digit palpates the cricothyroid. I've got these models upstairs, I'll show you, but for the sake of just getting through this here, be careful about post-cric in terms of pneumothorax, and also over insertion, because that can simulate pneumothorax. But you want to be careful about your depth of placement and watch for tension pneumo. So here's a lab example, and maybe. All right. So you'll have to come upstairs, and I will take you through the step-by-steps. But I want to share with you, because we need a little bit of, Michael and I talk a lot about something called the beauty to death ratio. Years ago, I came to the conclusion that working in this business of people dying all the time, I needed to increase my beauty to counteract all the death. For those of you who've gone off to parts of the world where there's even more death, my hat's off to you, by the way, for those of you who do that. But I think you need to be, I mean, there's enough death in my world of emergency medicine in America, but I think you need to balance the death with the beauty. So that's why I come to Zermatt. That's why I run a course in the Tetons. But anyway, there is also a need for humor. So hopefully this will run.
For persons without training in medicine or surgery, the safest and fastest method of making a surgical airway is to place an opening between the two large cartilages of the larynx, or Adam's
Is there
apple.
any way I can just scroll through? Can I just swipe? No, I just want to move my...
This
is
can be
a-
illustrated with an anatomical
if you can
specimen.
just... Oh,
This
okay.
larynx shows the large thyroid cartilage.
No, hang on. I just wanted to play something, but, all right. But let's go to the next one. So, but what I was going to show you was at the end of this introduction, they take a disarticulated human larynx. And I don't know if you could scroll to it, the end of the last video. But they take a disarticulated human larynx and they spin it around. And they show you the high back wall. So can you? Okay, so but can you start it? And then just, can you scroll forward or no?
For persons
Can you
without
just keep
training
going
in
all the way to the
medicine or
back?
surgery, the safest and
No?
fastest
All right.
method of making...
So, sorry, I want to get to these other ones. So they show the posterior elements, which is the cartilaginous cage. And it's kind of cool to look at that because they take a knife and they just butt it into this open larynx and they show you how hard it is. But the rest of the video is just priceless.
For persons without...
Oh, hang on. Is it the same one? Ah, killing me. All right, can you play that one?
For persons without training
You
in
can't
medicine
scroll?
or surgery, the safest and
All
fastest
right, can you
method
turn
of
off
making
the
a surgical
audio?
airway is to place an opening between the two large cartilages.
We'll see if it gets there. But what I was going to show you is, the last slide is of a practice sheet. But I think I'll see if we get to this, but there's a disarticulated specimen. But we need to change how we train. This notion that we can go to a sim center once or twice a year is absurd. The notion that you can do an airway workshop once or twice a year is absurd. In the world of the military, which I was 58 years old and I decided, bored, what else am I going to do? I up and joined the freaking military. I don't know what I was thinking. But anyway, I didn't know anything about handling a weapon. But when you're handling a weapon, it's about dry fire time. It's about how much practice you have holding this weapon. And I think like we need to give models to our trainees, have them use them every day, 2 or 3 times a day for 30 days. And then you bring them back and you blindfold them and you say, okay, go. And that muscle memory needs to be there. Otherwise, you are not going to get this. This notion that you can practice this infrequently and do these, high acuity, low opportunity things well, you're lying to yourself and your trainees. All right, I'm not sure we're going to get, because it turns into one video that I think we have to move on for 5 minutes. But, Michael, how are we on time? We're fine. All right. So, but there's no way to actually grab the video in advance. This is why I hate PowerPoint. Wow. All right. So let me tell you about this case I had while we're seeing if it'll get there. But basically, this woman was developmentally delayed, and she basically was eating and then choked. EMS got called. They attempted ventilation. They tried an eye gel. They couldn't get it in. They did laryngoscopy with video. What they thought they were looking at was the base of the tongue, but it was in fact a large sandwich roll over her larynx. And about 5,000 people a year in the States die this way, unfortunately. And yeah, so I knew she was coming, and I just told the nurses, we're going to go right to cric. I went out and I told the family I did this. And they were very appreciative, even though we didn't get her back. But she was 30 years old, and she died. And, to tell the family, hey, I cut into her neck because she was choking and everything else was obstructed, and they were like, thank you for trying. And that alone was a valuable thing. Anyway. So, I'm not sure we're going to get to my video in time here. So upstairs, I have models that I made from this anatomic model I got from Paris in 1835 by a guy named Louis Thomas Jefferson Azou. And I made it in male and female. And I have simplified surgical skins that are 3 layers that cost 5 cents. And you can buy their shipping labels with cotton padding in between, self-adhesive shipping labels. And I put them on cadavers, and I can repeat. What's that? So there's the scalpel. We're seeing this. It's a jackknife. Yeah, let's see if this keeps playing, and we'll see if it does or not. But they spin around. So this is the view I was telling you about, that they take a look. We can come up on the audio a little. And they take a look at the...
Prevent you from pushing the instrument too far.
And then they show, so there's the high back wall of the cricoid. This was an aha moment for me.
The resistance provided by the back surface of the thick cricoid cartilage. A surgical airway can be made with anything that will cut through the skin.
It gets better. Oh my God.
Such as a pocket knife.
We need a little bit of humor, Michael. I'm going over for a few minutes.
Razor blade.
So the full video is on my website, airwaycam.com, but they just
Even
go...
a piece of glass or a fragment of tin can will be adequate for cutting. The opening made into the cricothyroid membrane may be maintained with the barrel of a fountain pen. Or
A fountain
ballpoint
pen.
with the ends removed. Rubber tubing. Plastic tubing.
Sorry. All right.
Or with a standard tracheostomy tube. Moreover, for short periods of time, the airway can be kept open by nail clippers or a pair of keys.
Isn't that awesome? Now, what was really impressive about this video is they then take Navy
Emergency
volunteers
airway is a quick, deliberate
and
operation
demonstrate
done in 4
it.
steps. One,
Thank God for the U.S.
locate
Navy.
landmark,
I'm sorry,
the
political
thyroid
statement,
cartilage
but
above and the cricoid cartilage below with the soft
It doesn't get
membrane
any better.
between.
anyway, no gloves, it's 1950s. Well, anyway, I wish I could advance because they get to the nail clippers, they
Make a
get to the
transverse
keys.
Incision 1 to 2 inches long, centered between these 2 cartilages.
Yeah. Well, so this is, you know, using an actual surgical instrument, but then they go on and they go to the next things, and yeah.
3, relocate the landmarks as you steady the larynx.
So they cut the skin. Now they do horizontal. I would do
4,
vertical.
Cut or puncture the membrane transversely and enlarge the opening.
And
Note
it
there is
stops
little or
where
no
the
bleeding,
thyroid
since there are
overlaps.
very few blood vessels in this area of the neck.
And all bleeding stops.
In order to keep the puncture open
This is the
and enable the patient
1950s.
to obtain enough air to sustain life, a tube must be placed in the opening.
Now here's where it gets fun.
Almost any type of tubing will
No,
suffice.
no. Come on. Sorry. All right, Michael. I could keep going. This just keeps going. But they get to the fun instruments next. Is that an oral airway?
Whatever tubing is used, it need not be sterilized, since any risk of infection is far less critical than the risk of suffocation.
That's true.
If no tube is available, the puncture in the windpipe may be held open temporarily by using an ordinary nail clippers like this.
Now, I would think about some amphotericin after that, but
Or you can keep the puncture open temporarily with 2 keys or anything else that will do the job.
anyway, this video is amazing.
To prevent
All right,
the
I
tube
think
from
we should
being
stop though,
dislodged.
because I could keep going. But they show all of these instruments, cutting with chunks of glass and throwing keys in. Here's this cric sheet, and if you put one of these by your bedside every day and you did it 5 times a day, and then 30 days later, and you can practice it with a pen, and a piece of paper, just go through the steps. So it's like, you know, Jim in the salad technique, right? He has practiced this so many times, and that's what he teaches his EMS people. Michael doing these techniques, and if you think about skills, right? You think about the cardiothoracic surgeons, you think about anybody who does anything well, it is high repetition, practiced again and again and again. So I have gone over. Sorry about the video. Thank you much.
Thank you. Thank you very much. Rich, do they have to bring the nail clipper themselves to the workshop, or do you provide one? You got it all, I thought so. Okay, so we came to this point in the bleeding airway algorithm. This could be an awake front of neck access or an awake intubation. And the techniques, these are techniques that are not dependent on optics or vision, but can be done blindly. And two of those you'll be able to practice in the workshop: intubation via supraglottic airway and retrograde intubation. I'll show an example of this. This is a known difficult airway. He had been to surgery some weeks before, needed an awake intubation. Now he comes in. This is the surgeon compressing. He's sitting up. He comes from the ER to my smallest operation suite, and he's fully awake. And what to do? Oh. This, can you maybe click the video? There's no video. I bet there is. Okay, so now that's an temptation to go to our webpage, airman.deco. There is a link to the video. You'll all practice this in the workshop. There is a bloody video. Okay. Okay. Special circumstances where we are out of hospital or in other strange places. Søren, please tell us how to manage this.
Thank you, Michael. Michael asked me this question just the other day, and wow, Michael, putting me into a room with so many experienced pre-hospital clinicians, and after Mr. Vomit Master and Airway Cam, thank you very much. Well, I'm not an expert. I do work pre-hospitally, I do work with ENT anesthesia, and I have spent so many hours discussing these problems with Michael, with our team back in Copenhagen. So I do have some thoughts I want to share with you. So the first thing is that Michael alluded to the Canadian airway algorithm, and I think this is a brilliant algorithm. And he went through it, and there was this point where it says, are there any complicating contextual issues that might impact the decision? And that's a question. But it's more, this is probably the essence of pre-hospital management. But you have to reframe it and say, there are complicating contextual issues that will impact your decision. Adverse locations, remote locations, difficult access, poor lighting, backup isn't available. You can't carry an infinite amount of gear with you. We try, but we can't. And the teams are almost always made up of ad hoc units coming together for this just one patient. And there may be very little experience with airway management within that combined team. So communication can be difficult. How do you communicate what is your plan? And the obvious need that the patient has, they need to go to the hospital and get proper treatment. We need to go, go, go. So everything we do pre-hospitally is a compromise. You have to choose whatever is the best but most meaningful intervention. And that is our job as pre-hospital airway management providers. What is not different from what we do inside the hospital is that stop, slow down. It's a very few patients that actually need an intubation right now. We need to make a proper plan. For all of you HEMS guys, you know when we encounter bad weather, the pilot says, stop, slow down, navigate. This is what we need to do when we plan for airway management outside the hospital. If we look towards the science, does it give us an answer what is the best way of doing airway management? And this is a meta-analysis published in the Prehospital Emergency Care just a few years ago, and it's not really, doesn't really give us the answer. There's no evidence of what is the best way of providing airway management. So again, it's a compromise. So I would urge you to do everything what Jim and Michael and Rich said, take that into the street. Manipulate your environment and use the best meaningful interventions available to you. But I have a few thoughts where I think we can improve and where we should do something that might be better. We are incredibly good at intubation. This has been shown in a series of good studies in the past few years, that especially when using video laryngoscopy, our first pass success is very high outside the hospital. But I urge you that intubation should not be a tick box procedure that we just do because we can. No, there are categories of patients that we actually should stay away from intubating. This is a retrospective study from the London HEMS, where they looked at severely injured patients and looking at would it affect in-hospital mortality if you put them under anesthesia and did an RSI pre-hospitally if you were awake. Many of us would think that it doesn't really make a difference, and let's get the airway sorted, get that out of the way. But actually, if you are awake and hypertensive pre-hospitally, you are more likely to die if we put you under anesthesia and put a tube in you. So be mindful that the patient will need some resuscitation before you actually do the intubation. This is, of course, a retrospective study, and there is bias, confining by indication bias, of course. Entitled CO2, mandatory. We knew that from the NAP4 study. I think it's implemented in pretty much everywhere. Waveform capnography. Just last year, this very, very nice paper guideline was published in anesthesia, and it really defines what are the criteria for waveform capnography in identifying the esophageal intubation. Very good paper, but it doesn't only give us what's the criteria. It also provides us with a framework of what to do if things doesn't add up. Very good paper. Go and read that. Next one, ketamine. I love ketamine professionally, of course. But I would say that ketamine is an airway drug. You've all met this guy. Put whatever condition you can think of. He is hypoxic, he is delirious, he's crazy, and he needs an intubation, but he doesn't want pre-oxygenation. He's the can't pre-oxygenate patient. Whatever you do, he will combat you, he will fight you, he will not wear the mask. So this is where you need to have ketamine as in delayed sequence intubation as the part of your toolbox. Promoted by Scott Weingart, and used, this was the original study that we did. Go and read that paper. This also both describes the techniques and the thoughts behind it. And in this very diverse critically ill patient population, we showed that actually it works. It will increase your oxygenation or your saturation prior to intubation, and it did work without any problems in this study. It's been studied pre-hospitally also. In Australia, if you start using a protocol where you do you use delayed sequence intubation, it will reduce your incidence of patients with hypoxia on intubation. And they, as the Australians are very polite, they consider this a reasonable and safe, effective approach pre-hospitally. Also been studied in children, but only in case reports. But the real thing about using delayed sequence intubation, it gives you all these added benefits, but mostly important, it gives you time, it gives you control of the situation. So next up, measuring saturations. You've all tried this, you put on the probe, and there's a really, really poor signal. It might be due to low perfusion, noise artifact in the back of an ambulance or a helicopter, motion artifacts. You do whatever you try to switch around the saturation probe, doesn't give you any better reading. There are different saturation probes for different orifices. I don't know whether these are they are used in any of your pre-hospital services, not in mine. But you can make your own. Take the pediatric saturation monitor, stick that on the backside of an oral pharyngeal airway, and stick that into the mouth. And it works beautifully. Get a really, really nice and stable saturation read. Yes. So this is actually coming back to everything that Michael and Rich and Jim said. Have a structured approach for the rarely encountered situations. The surgical inevitable airway, the smashed face. But know what technique you want to use. Practice that. What is your backup? What is your escape plan if that technique fails? Identify the cricothyroid membrane in patients where it might not be in the place where you actually expect it to be. Have a standard approach for that. The bleeding airway, we already touched on that. Have a standard approach for that. Does this patient need intubation before going on to the helicopter flight? We're in a rural hospital. We don't have a fiber optic scope. What's your plan? Have a thought about these situations before you encounter them, even though they are rare. And then, something that is controversial, in-flight intubation. I don't do this. I've never done it. So hands up, how many of you consider in-flight or en route intubation a part of your standard practice that's safe? A few guys here. My friend Michael has, you have done this and you consider this to be safe.
It may be safe, but I have a suspicion that it's the small guys who find it attractive to do in the helicopter. At least that's what we believe is the difference between Søren and I. It's easy for me to not walk around in the helicopter, but at least find my way around in the helicopter, and it's more difficult for Søren. I did this. This patient had a perfectly, at least in the beginning, perfectly functioning supraglottic airway. But in flight, it turned out to be not efficient enough. I decided not to ask the pilot to land, mainly because we were at seaside. But luckily, we have a video laryngoscope, and it's easy for me to be in a proper position alongside the patient. And actually, without any drama at all, I took out the LMA and put in the ET tube and A-line, now that I was there. And the paramedic hadn't seen it that many times, which this expression on his face may indicate, but it ended out as a success. And of course, you should have a plan for this, because it's probably better to intubate the patients that need a tube before you fly, but you will give some patients the benefit of the doubt if you don't intubate, unless it turns out that they really need it. Conclusion is, have a plan for in-flight intubation as well. This is a Japanese study. They fly with 376 patients, half of them intubated prior to takeoff, the other half in the helicopter. They have 3 healthcare providers in an EC-135 helicopter, which is amazing, but certainly not 3 of Søren's size. But they managed to intubate equally successfully in flight as prior to takeoff. Another thing to say that in-flight intubation is a technique that may be the right thing to do in some situations. One of the points, and back to Søren.
And last but not least, you can't do a pre-hospital talk without a hero shot. So this is my hero shot. And back to you, Michael.
Yeah, thank you. Okay, give me the pointer, please. No, we have questions and comments after.
No, I know. What about the in-flight RSI? So AirSomat, we've been doing this for a couple of years. And actually, I kind of disagree. We've done it very, very successfully, and we found out that, especially in our environment, cold temperature, it's much, much easier to do it because we have 40 minutes flight to the hospital. We have the ventilator right here. We have the O2 ball right here. The patient is perfect. We have video learning scope. And instead of bringing the whole hospital outside from the helicopter, trying to establish it, spending half an hour on scene, we ought to just take the patient in, fly, everything is quiet, no wind, better temperature control. We have everything we need. We love it.
How do we get a job in your service, mate?
This should be standard these days.
Excellent, thank you very much. Okay, so breaking news. Publishing this week, infrared flashing light through the cricothyroid membrane as guidance to awake intubation with flexible bronchoscope, a randomized crossover study. What we already know is this: sometimes there is such a severe pathology we can't find our way, not even in an awake patient with a flexible scope, because we go for the small hole in the big hole, we go for the entrance to the trachea in the mouth or the pharynx, and we don't know where it is, but we know that it would be nice if we had flashing light coming towards us to direct us where to come. And this is one of the first parts. We know that it's possible in selected cases. She's scheduled for awake intubation. She has some oxygen. She gets this on her cricothyroid membrane, either identified by palpation or by ultrasonography, gets a bit of the best drug for airway management, that is xylocaine, and put on this emitter of infrared light, so you can't see much. This does an indicator light, but then you use a flexible scope that can detect this wavelengths between 700 and 1,000 nanometers. And when you do that, instead of seeing some gray and dark, we will see this. You see the uvula first, of course. There's a bit of suspense here. Oh, let's see, please. At the end of the Swiss tunnel, you see nice flashing light coming towards us, telling us where to go. So we knew that, and this is another case with more significant pathology. We go in there. Oh, it's not that easy to see what might be the gastrointestinal channel, what might be the airway, what might be tumors. It would be nice if you get some guidance here. The patient is awake. You saw a flashing light. Is it over there? No, it's not over there. Please, we have to get around this one. Okay, there we got it. We advance the flexible scope until we are mid-trachea and slide the tube over it. So that was all known. This is another case. I like this one because our surgeons wrote in the file, inability to visualize the vocal cords due to a pronounced swelling. So they couldn't see anything. Say, that's a case for infrared guidance. But we would like to know whether this is actually beneficial in clinical practice, maybe in less severe patients. So we took patients for awake, all intubation with a flexible scope, and the endoscopists were the doctor allocated to that room. That could be a residence, for instance. And then we gave each patient 2 insertions with a flexible scope in a randomized crossover fashion. One group had, they were all awake, infrared first and then non-infrared, and the other group had infrared flashing light first and then infrared second. And the primary endpoint is where on our journey towards the windpipe can we see the vocal cords or the flashing light. So the higher, the easier direction towards the airway. We had 44 insertions in 22 patients, and we present. Could you please click this link, and then we'll see whether it's not connected to the internet. Are we in Switzerland or what? Okay, we present the primary endpoint as all the original videos, so you as a reader can decide by yourself. Okay, so these are the results. The red is with the infrared flashing light there. Sometimes you could see it already in the oral cavity, and you see that in 2/3 of cases already in the oral pharynx, you could see in which direction to go. Whereas if we don't use the infrared light, we have to go all the way to beyond the tip of the epiglottis to see where to go. And it's also faster before we see it. So we conclude, or we also ask, is it easier? And 1 is impossible, and 10 is very easy. And you see, again, red is with the infrared flashing light, and this was highly significantly easier. So we conclude that you get an unequivocal guidance towards the windpipe with this technique, and it was beneficial. Okay, the last point before we introduce the hands-on workshop is, what about the future? Wouldn't it be nice to have a technique that is useful for awake or anesthetized muscle relaxed patients, that can be used without any device in the airway, with adjustable FiO2, so that we use it, for instance, for laser surgery, with a physiological, better hemodynamic profile than positive pressure ventilation. Who would like that? The future is right around the corner. You can have it demonstrated up here tonight. This is a cuirass external ventilation, and this is a picture of 3 years ago when I tried it first time, and I can't help smiling because for the first time in my life, I didn't even have to breathe. So it's extra relaxing. The last effort, moving the diaphragm, you didn't have to do that. You almost fall asleep. The cuirass, biphasic cuirass ventilation. Amazing, it works. Don't tell me it's not a video. Okay, so a reason to come back. So what it does, we apply negative pressure. I tell you the videos work before we hook them up here. You apply negative pressure, then the thoracic cage will expand and the diaphragm will go down. Then you apply positive pressure, then it goes the other way around. You can actually have active expiration, and you can do that with any frequency you want and any pressure difference that you want. There are publications to support this in patients with respiratory insufficiency, for instance, neuromuscular blockade or disease. And there is a positive hemodynamic profile with increased cardiac output, which is easy to understand because this will obviously increase the blood flow to the right side of the heart. So we are now implementing this for surgery, where we need surgery in the airway, but we don't have space for any devices. First, we test on ourselves, or rather on our residents. He's not intubated, just to test whether it works to optimize tidal volumes. Next, we refine CO2 sampling, also at residents. So they are very useful for our daily practice. Yes, come and have fun in our place. And then invite the surgeons and use our artificial man, the sim man from Leerdale, put him in the operating room to refine the setup there. How can we make the surgical instruments fit and have the cuirass on the patient at the same time? So we plan everything. And what about real patients? Yes, we are implementing this. This is one of our early patients, Marianne. She looks harmless. She can even open her mouth. But in there, she has a chondrosarcoma plus multiple lesions of unknown origin. Previously, it has been tried with apnea, high-flow nasal oxygenation, and jet ventilation with difficult or impossible access. She needs a longer time access because we need to use a shaver to cut this off. So, first step, general anesthesia, mask, ventilation, transcutaneous CO2, arterial line, placing the cuirass, and then optimizing cuirass ventilation by measuring the minute volume through the anesthesia machine, to the mask, and then place the surgical equipment, then the desired oxygen mixture via the nose, and ready to go. It looks like this. You have, of course, have to keep the airway open. And you can see general anesthesia, muscle relaxed, breathing, and allowing the surgeon a totally uncompromised access to the airway without even the movement that comes from jet ventilation. And you see they almost forget what we are doing here. And you see this huge metal rod actually operating in the trachea while the patient is being ventilated. And you see here the CO2 at the beginning, and after almost an hour, even able to hyperventilate a bit. And we were very happy, the team. The first times, we are still happy, but the first couple of times we felt like a big success. And so it's good for anesthesia, but what do the surgeons say? Hey, these are my surgeons, Jakob and Christian. What do you think about this technique compared to jet ventilation?
It is far better than jet ventilation. The field is quiet, the field is still, you don't have that flapping movement of jet going back and forth. You've got no other instruments going down the narrow space that you have to work in. So in cases of compromised access or minimal access, it's a lot easier.
Hey, these are... Okay, and we are going to come up with the necessary cookbook and documentation for this working. That will be our aim. And you can all try it up here on yourself, on your peers, and see how it feels. I think it's amazing. Okay. Now, introduction of the hands-on workshop that will start in 22 minutes. We will have 5 stations. One is ultrasound identification of cricoid membrane on a live subject. Second is front of neck airway access with both Rich and the male and the female model, and our colleagues from the Netherlands on a different model. Cuirass ventilation that we'll demonstrate. I'll demonstrate together with John from Geneva. And then the airway bazaar, where you can practice retrograde intubation, the TTIP ventilation, infrared guidance of the flexible scope intubation, and intubation via supraglottic airway devices, and the bloody bleeding airway, where you can practice both the anatomically difficult airway, where you cannot expect that suction will solve the problem, and the anatomical easy airway, where salad suctioning may be the saving tool. Okay, so they are up there in the breakfast restaurant Alice, start at 1900 hours, marked 1 to 5. This year, you are so many participants, we have decided not to make a rotation. So, but it's clearly marked with signs. Choose what will have your priority and go shop around. Share your experience, please, because this is an exchange of experience, not a one-way thing. We want to pick all of your brains as well. Okay. So, a few questions now, otherwise you will have ample time at the workshop. So, you're all tired and thirsty, of course. Then, questions we're at the workshop. Thank you for your attention. Thank you.